Good morning. I would like to welcome everyone to today's clinical meeting. We have a large number of cases today, and we would like to welcome the departments of respiratory medicine and also a team from ODC who are going to be joining us today for our clinical meeting. We would like to welcome the presenter from respiratory medicine to present the first case.
Good morning, everybody. I'm Jemimah from. Good morning, everybody. I'm Jemimah from Respiratory Medicine. I'm here to present on breaking the shackles. Here we have a 54-year-old female, non-smoker, non-diabetic and hypertensive, presented with right-sided pleuritic chest pain for 1 month, high-grade intermittent fever and cough with minimal mucoid expectoration for 2 weeks, no breathlessness or loss of weight or loss of appetite, no CTD symptoms. On examination, she was febrile. General examination was unremarkable. Respiratory system examination showed no chest wall tenderness, swelling, or discharging sinuses. And on auscultation, there was absent breath sounds over the right infrascapular, interscapular, and infraaxillary regions, and stony dullness was present on percussion in the same areas. Investigation showed elevated counts with left shift. ECG showed sinus tachycardia, and here the chest X-ray, we can see a homogeneous convex shaped opacity, which is pleural based in the right, mid, and lower zones with CP angle blunting. So we did the ultrasound chest and it showed loculated collection with multiple internal septations and parietal pleural thickening. She underwent the ultrasound guided pleural tapping, which yielded 30 ml of deep straw colored fluid. The pleural fluid analysis was suggestive of neutrophilic predominant exudative effusion by Light's criteria, and the pH was less than 6.8 and the glucose was less than 5. The pleural fluid expert TB PCR was negative. Since the diagnostic tap was suggestive of a complex paranpneumonic effusion, insertion of a chest drain was planned. At the same time, in view of 1 month history, we also planned for a USG guided pleural biopsy. Meanwhile, patient was started on augmentin. So this is the chest X-ray post biopsy and ICD insertion. We can see that the lung is not showing optimal expansion. So we got the pleural fluid reports and it was positive for alpha hemolytic streptococci sensitive to linezolid and levofloxacin, and the biopsy reports were also negative for any granulomas or malignancy. So the antibiotic was changed according to the sensitivity pattern. So here, as the lung did not show optimal expansion, we did the USG screening and it showed presence of multiple internal septation. In view of the suboptimal radiological improvement with the ICD insertion, a trial of fibrinolytic therapy was planned. Here, intrapleural streptokinase with a dose of 2.5 lakh international units, a total of 6 doses, each 12 hours apart, was given. So this is the overall progression of this patient. This is the first chest X-ray at admission, and second is the post ICD insertion. We can see that the lung is not completely expanded, and this is the chest X-ray post streptokinase. We can see that the effusion is slowly clearing, and this is the follow-up chest X-ray 4 weeks in OPD, and it shows complete clearance of the pleural effusion. So now we are going to see the classification of the paranpneumonic effusion. Stage 1 is the simple exudate where the pH is more than 7.3, glucose is more than 60 and LDH is less than 1000. Here on USG screening there are no loculations and the effusion is free flowing. Stage 2 is the fibrinopurulent stage where the pH becomes less than 7.20 and glucose is less than 40 and LDH is more than 1000. And here we can see that the USG screening, there is a tendency towards multiple septations and loculations. And stage 3 is the organizing stage where there is visceral pleural thickening and trapped lung. So for treatment of a complicated parapneumonic effusion, for therapeutic resolution, it requires appropriate antibiotic regimen plus pleural drainage. In the presence of septations and multiple localization, it prevents the complete evacuation of the fluid just by intercostal drainage. So in those cases, they will either require a intrapleural fibrinolytic therapy or medical thoracoscopy or surgery, along with other supportive managements like appropriate nutrition and thromboprophylaxis. So what is the role of intrapleural fibrinolytics? What does the evidence say? Here is two meta-analysis of RCT. It suggests that treatment with fibrinolytics is potentially effective in reducing the need for surgery and it improves the fluid drainage. But those evidence was insufficient to support for routine use. Here are two landmark trials, MIST-1 and MIST-2, but it refutes the role of fibrinolytics for parapneumonic effusion and empyema. But in MIST-2 trial, a combination of TPA and DNase was useful for treating PPA and empyema, and the benefits of this combination were confirmed by other studies also, and it prevented surgery in 91% of the cases. So all these are all these are international studies. So to extrapolate to our population was difficult. Here we have what our Indian evidence says. So there are 200 patients with loculated pleural effusion and failed tube drainage who underwent intrapleural fibrinolytic therapy. Here we can see that the efficacy of both streptokinase and urokinase was similar in both the cases. And on another study with 66 patients, the efficacy of both streptokinase and urokinase was still the same. And it showed good clinical and radiological responses in both the streptokinase and urokinase arm. So coming to the conclusion and take home message, we can see that intrapleural fibrinolytics in complicated effusion and empyema may be used early only in selected cases where there is treatment failure or those candidates not fit for surgery. And ultrasound thorax should be used in all patients for stratifying the pleural effusion. And patients should be referred for surgery who are not fit for medical thoracoscopy or intrapleural fibrinolytics, and patients with stage 3 parapneumonic effusion. Thank you.
Thank you, Jemimah. Ma'am, did you have any comments that you wanted to add to this?
Hello, good morning, everyone. So this is Richa from Respiratory Medicine. What I wanted to say is, and the reason why we wanted to present this case was simple. We used to use streptokinase earlier, but then MIST-1 and MIST-2 trial, which are considered as the landmark trial, came in, done in UK. Both the trials, very big number of patients. And after that, that was sometimes in 2007 and 8 when it came in, and then we stopped using it because it says when they compare streptokinase versus placebo, there was no difference in terms of clinical or radiological improvement or the need for decreasing the need for surgery. So that's what we stopped. But then here and then, as and when we were using it. So there is a need. What we wanted to say was that if you ask any pulmonologist, MIST-1 and MIST-2 trial is like, the landmark trial. But we have seen the patients, none of the patients were Asian patients which were included. And we also feels that in India, probably the patient profile, the degree of, the disease or the viscosity of the fluid, what is there in Indian subcontinent probably is different. So there is some data, some retrospective studies, some Indian experience, which is prospective studies, where they felt that still in our population, it does work. But then we have to be careful that it cannot be used for all the patient. It has to be used very carefully because the risk of bleeding is certainly there. Though I understand that people do not use streptokinase for any kind of, later thrombolysis or anything is required. But some, even though it is used in pleura, there can be some systemic absorption. So if you are using it, it has to be mentioned very clearly. So later in 1 year or 2 year patient needs to be used as streptokinase, antibodies may be there and it may not function very well. So there is a role, but in only very selective patient should be referred to the specialist that in whom it can be used. And that is what we wanted to give a message. Not all patients are candidate. Stage 3, where you have a thick rind and it is, not improving, refer directly to the surgeons. We didn't present here medical thoracoscopy, but medical thoracoscopy has come in between fibrinolysis versus surgery, and we have good experience at our center itself where we have actually prevented lots of surgery for our patients who have shown really good improvement. So that was the message we wanted to give. I hope it is clear. Any questions are there? I'm happy to answer.
How long would you wait, ma'am, to see the resolution?
The resolution, right? So it goes on the so this patient, or for that matter any patient, when we are giving, when we feel that it is not draining properly, you give one dose, you give two doses, and then you look at whether the drain has increased. If the drain has increased and it is not turned hemorrhagic, you can continue to give the dose. So what we do is after 3 doses we repeat a chest x-ray to see how the improvement is, and then usually 3 days, but there is no set and written in Bible that it has to be 3 days. If there is significant improvement after 3 doses or even 2 doses, you can stop it. If it is converting into hemorrhage, stop. Do not do it. Repeat a chest x-ray. If drain is not increasing despite you have given, stop. It is not working. And also one thing is there, that for the pleural thickening, fibrinolytic therapy is not used for the pleural thickening. It is only for the internal septations within the locule.
Thank you, ma'am.
At what point during the treatment of the pneumonia with the paralytic diffusion do we start considering, like, would you wait, give antibiotic therapy and wait and see? Like, at what point do we consider the fact?
Right. So if it is a free fluid, we know, right? Drainage is must for a parapneumonic effusion. We agree on that, right? If it is a free fluid, then and you put a chest drain, it has to be done. And you give antibiotic. If it is clinical and radiological improvement is there, no need to do anything. But if there is no improvement or there are loculation to start with an ultrasonography, you put a chest drain, not draining, or even if it is draining but radiological improvement is not good, that may be the time. So as early as possible. The earlier you use, the better it is. If you are going to delay it, then more septations, more thickening will happen.
Thank you, ma'am. Thank you, Jemimah. Our next case will actually be the case from ODC. This will be a presentation via Zoom.
Good morning. Good morning, everyone.